Good evening, everybody, and welcome to this Prostate Cancer UK webinar titled Enlarged Prostates, Coping with Symptoms and Treatment Options. I'm Jonathan Kay, and I'm the Health Information Service Lead at Prostate Cancer UK, and I'll be the host for this evening. Before we get going properly, I just need to go through a little bit of housekeeping for everybody, and apologies if you've been on one of our webinars before. Unfortunately, you'll be hearing a very similar messages to last time. But firstly, we're here on a Zoom webinar. This isn't the same as a Zoom meeting. So you won't be able to, you don't need to worry about making any sound or hear or communicating with others. The only people you'll be able to hear and see are the people on the panel. So yeah, you don't need to worry about your microphone or your camera. As we're going through, if you've got any questions for the panel, please use the Q&A function at the bottom of the screen to submit them. I'm very glad that we're here with Meg and Grace, who are both specialist nurses here at Prostate Cancer UK, and they're on hand to respond to the questions in the chat. We'll also have some dedicated time for a Q&A discussion at the end, where we'll aim to get through some of the more detailed questions. Sorry if we don't get to your question this evening. If you're left with any urgent questions, remember that you can contact our specialist nurses, and they're available Monday to Friday, 9 to 5, and the details are available on our website. We'll aim to collate the unanswered questions and answer them in a summary email in the coming days. And also, please note that everything in this webinar is for general information purposes to help you understand and navigate your situation better. It doesn't constitute medical advice. Importantly, we'll be covering issues that some of you might find challenging. If you, sorry, I've lost my place here. If you find it difficult to listen at any point, you can, of course, step away. We'll circulate a recording of the webinar afterwards, so you can catch up in your own time if you prefer. I'm delighted to be joined by our wonderful panel encompassing clinical expertise and lived experience. I'll let them introduce themselves very briefly, and hopefully they'll appear on your screen now. So start off, pass you over to Wissam.
Hello, everyone. My name is Wissam Oushadid. I'm a urology consultant at the Royal Surrey Hospital, and I specialize mostly in benign enlargement of the prostate and prostate cancer treatments.
Thank you, Wissam. And I'll pass you over to Roddy now.
Hi, everyone. I'm Roddy Hutchison. I'm an example of someone who's been through the experience of living with an enlarged prostate and eventually opting for surgery to improve things.
Great. Thank you, Roddy. Right, so the other member of our panel tonight is Lisa Hilder, who's one of our clinical nurse specialists at Prostate Cancer UK. She unfortunately can't be with us for the start of the webinar, but she's recorded her introductory talk for us, which I'll be playing in a few minutes. And we're hoping that she'll be able to join us within the Q&As towards the end of the webinar. But if not, Meg will be on hand to fill her place. Like I said, I'll begin her recording in a moment shortly, but first we're going to do a quick poll, as we'd like to get a better understanding of our audience that's with us today. So what I'm going to do now, if you just bear with me a second, is flash up our first poll. Hopefully you can see that on screen. But like I said, we'd love to know more about our audience today. So please, can you select which of the following applies to you? Don't worry, this is completely anonymous, but yeah, we're looking at men who have maybe got an enlarged prostate but are managing it with lifestyle changes, those that have got an enlarged prostate and are currently using medication to treat the condition, those men that have already had surgery for an enlarged prostate, or if you're just concerned about, about what an enlarged prostate might be, or maybe you've got some symptoms and you want to learn some more information about it. So I'll just keep that open for a few minutes, or a few seconds. It get a bit boring if we open it for a few minutes. We've had 71 out of 81 of you answered so far. So I'll just leave it open for a little bit longer. Okay, and I'll end the poll there. Thank you very much for participating in that. So yeah, it looks like most of you are at the point where you've got an enlarged prostate that's being dealt with in terms of medication, but there's also a good chunk of you that are also either have an enlarged prostate that's being managed by lifestyle choices or are concerned about it. So thank you very much for completing that. So just to give you a little bit of an overview of what we're going to be talking about today. So during this webinar, you'll hear about some of the challenges that can occur due to the side effects of an enlarged prostate and some of the treatments associated with it. We'll focus on the various medications and surgical options. We'll also talk about some of the lifestyle changes and support options you might want to explore for your own situation. You'll also hear about men like yourselves who have coped with these challenges as part of their own enlarged prostate journeys. So I'm now going to pass over to the recording of Lisa, who'll give you an introduction to enlarged prostates. So just let me share my screen. Right, hopefully that is now being shared and I just need to play it.
Thanks, Jonathan. So what is an enlarged prostate? An enlarged prostate is an increase in the size of the prostate, an increase in prostate cell growth. It is not prostate cancer, and it does not increase your risk of prostate cancer. An enlarged prostate is also known as a benign prostate enlargement, or BPE, and also a benign prostatic hyperplasia, BPH. These terms are interchangeable and mean the same thing. Now, I quite like my analogies, and I always think the prostate's a little bit like a ring donut, and the water pipe, the urethra, runs straight through the middle. With an enlarged prostate, it's more like a jam donut. So the jam is squeezing on the water pipe, that's the enlargement, and that's what can cause the urinary symptom. So what does cause an enlarged prostate? So we don't actually know the exact cause. We do, however, know that it's common in men over the age of 50, but it can affect younger men. We also know that it can be caused by an imbalance of hormones, both estrogen and testosterone, which changes as men get older. Some studies suggest obese men, men who have diabetes, and men who have a family history of an enlarged prostate might be at higher risk. However, we need more studies to decide if this is correct. Around 1 in 3 men over the age of 50 have urinary symptoms, which are mainly caused by an enlarged prostate. So what are the symptoms? Common symptoms of an enlarged prostate include changes to urinary flow, for example, hesitancy or trouble starting, a weak or poor flow, an intermittent or start-stop flow. Some men feel they don't empty their bladder fully when passing urine, frequency or going to the toilet more often, an urgency where you have to rush to the toilet, and getting up at night, which is known as nocturia. Some men have to strain or push on their tummy to get their flow started, and some men experience dribbling once they've finished their main flow. Some men leak urine either on the way to the toilet or just throughout the normal day. And although rare, some men do experience blood in their urine. Some men have symptoms, but some don't have any symptoms at all. We know that the severity of symptoms is not related to the size of the prostate. For example, you can have a small enlargement and have lots of symptoms, or have a big enlargement and not have many symptoms at all. Not all men get every symptom, and they can be caused by other things. For example, anxiety, diabetes or other medical conditions, the cold weather, recreational drug use or alcohol use, lifestyle choices, and prescribed medications. These symptoms of an enlarged prostate can affect a man's quality of life. So some of the symptoms are mild, which do not affect the quality. However, some men find that they do have to plan to be near a toilet, which can make it difficult to work, to drive, or to be physically active. Some men who get up at night have less sleep and this can make you tired during the following day, which also has a knock-on to quality of life. Some men with enlarged prostates need catheters, and these can present their own problems. A catheter is a tube that drains urine from the bladder through the penis to a bag on the leg. Some men also experience repeated infections with an enlarged prostate, especially if they're not able to empty their bladder fully. Stagnant urine can sit at the base of the bladder, and this can cause repeated infection. Having an enlarged prostate will give an increased risk of urinary retention. You're also more likely to be at risk if you're age 70 or over. You have a very large prostate. You have a raised prostate-specific antigen or PSA level. You have a very poor flow. There are two types of urinary retention, chronic and acute. Chronic retention develops over time and is where you pass small amounts of urine. Your tummy might feel swollen, or you may feel that you are peeing less than you drink, not emptying your bladder fully. Chronic retention is usually painless. The buildup of urine can stretch the bladder muscle and make it weaker. This can lead to increased risk of an infection, frequency, nocturia, leaking urine, and also painful bladder stones. It can also damage the bladder and kidneys if left untreated. Acute urinary retention is a sudden, painful inability to pass urine. It is an emergency and needs treating straight away. Approximately 1 in 100 men will experience acute retention. Men who call our helpline tell us that they do feel alone. They have a reduced quality of life. They call us asking about different treatment options, which we'll be covering shortly. They say their symptoms are unmanageable, so we can talk to them about what they can do to help and what can be prescribed or what surgery might be available. Some men are scared about the treatments, about the potential side effects. And although I've said at the beginning it is not linked to prostate cancer, some men still do worry that it might be cancer causing this. We also get questions about catheters. Now it's back to you, Jonathan.
Okay, thank you to Lisa for that recording there. I hope that set a nice introduction to the topics that we're going to be talking about tonight. And just a reminder to everybody that, of course, you can drop your questions into the Q&A section. But now moving on, I'd like to welcome Roddy Hutchinson to the webinar. After many years of urinary complications and various hospital referrals, Roddy was diagnosed with an enlarged prostate. This was initially treated using medication and then eventually with surgery, as he's already mentioned in his introduction. He's here today to tell us his story and answer any questions you might have at the end of the webinar. So welcome, Roddy. How are you today?
I'm well, thank you very much.
Brilliant.
And I've just realized that more or less all of the above on the slides kind of at one stage or another referred to me. So hopefully what I'm going to say is relevant. So yes, my story is a bit complicated, so I'll try and not get bogged down in it. It began for me in 2008. I had suffered a number of recurring what I thought were urinary tract infections. So I went to the GP and they tried to culture bacteria in urine samples, but they didn't find anything. So at that point, I was referred to urology at Royal Surrey County Hospital. They gave me a very thorough examination. I had a CT scan on the urinary tract. I had cystoscopy, the good old digital rectal examination, and a uriflow test. And what they showed was that my uriflow profile was pretty good, and at that time I was fully emptying my bladder. The cystoscopy showed a slight impingement on the neck of the bladder. So at that point I was diagnosed with benign prostate hyperplasia. The supposed UTIs were diagnosed as recurrent prostatitis, and we don't need to say any more about that. That resolved itself over a number of months. I think it was caused by a physical mischief I did while I was doing some extra heavy DIY in the house. So I think we just park that. So I was at that point I was discharged with no follow-up. And so then we have to jump all the way forward to 2021. I had the misfortune to have an occurrence of orchitis, which is an infection of the testicle. My right testicle swelled dramatically, and it was extremely painful. I was prescribed oral antibiotics, but they didn't get on top of it. So I was hospitalized just for one day to get intravenous antibiotics. And eventually it took a couple of months, but that resolved. But what that did was it brought me back to the attention of the urology team. And I was called back in because one of the potential causes of the orchitis was that urine was not being, I wasn't emptying my bladder fully, and urine was getting into the plumbing where it shouldn't have been. So I had a second cystoscopy, which this time showed a very significant impingement on the neck of the bladder. DRE I had again, and it was described as prominent but no granulometry. I should say in 2008 my PSA was measured as part of the test, and it was 7, a little bit high. But in the immediate aftermath of the orchitis, it had climbed to 15. So we looked at this, and the view was and I should say the uriflow test that I had in 2021 did show that I was not properly emptying my bladder. And at that point, I started on tamsulosin to help with urine flow. And just as a sort of background point, looking at the slide which showed the symptoms of living with an enlarged prostate, I would say yes, that those symptoms were exactly the ones that I was dealing with. Increased frequency, difficulty getting a urine flow started, and this feeling, particularly at night, that I haven't emptied my bladder. And towards the end of this story, I was getting up 4, sometimes 5 times a night. That was rather unpleasant.
Can I just stop you there for a moment, Roddy?
Yeah,
I think
sure.
you've hit on some very important points there, and I think it'd be really interesting to hear from you. The story you've told is over a number of years with various different symptoms. And, how challenging was that for you to not have like a very clear and defined diagnosis with symptoms? And also, were you ever worried that it might be prostate cancer? You were having PSA tests and things like that.
That's a good question. Let's deal with was I worried that it was prostate cancer? Because I'm sure that is something that a lot of guys in my position will obviously be concerned about. In my own case, I was never particularly concerned, and I don't mean to sound blasé about that, but because I had the benefit of a suite of tests, the answers kept coming back. We don't see anything suspicious. Yes, you're showing all the signs of an enlarged prostate, but we don't see, granulometry in the DRE. The cystoscopy isn't showing anything untoward. And I did have, in 2022, I did have an MRI scan, which again didn't show any suspicious areas. And it also, that sort of quantified the size of my prostate. Was it challenging? Yes, I suppose. I, I should have said it right at the beginning. I'm retired. So in a way that helps, because daytime at least I could plan what I was going to be doing. But yes, this idea that, I can't be driving for 6 hours. I've got to think, I've got to be able to take the toilet breaks. But by and large, I could manage it. It didn't really get me down, with the exception of overnight, because I've never been the best sleeper in the world. And so this continually up and down that was really a drag.
Yeah, I can imagine it must have been.
Yeah.
So I think my next question then is, you just started to touch on that. You've gone from the point of diagnosis and starting to get treatment for it. So I think for a number of years, you were having various medications
Yes,
rather than surgery. Can you just focus on that point of your
of course.
journey, the different medications that you had?
So basically, the only medication that I took was tamsulosin. So the Americans call it Flomax. So that explains what it does. And I would say that at the beginning, it helped. It's a medicine it's a tablet that you take in the morning. You take it once a day in the morning, and its aim is to improve urine flow during the active part of the day. And yes, it does that. Its poorest performance is overnight, which is where in my particular case I would have loved it to work rather better. So I lived with that for from 2021 up until 2024. And in 2024, I had a follow-up to the 2022 MRI. Why the long gap? I think that was simply the chaos around COVID and all the rest of it. It took a while to catch up with me again. In mid 2024, we did another uriflow test, and the result was dreadful. My urine flow profile was terrible. My flow rate was just 10 milliliters per second, which is really low. And in terms of passing urine, it was very poor. In a full bladder, I retained more urine than I managed to pass. Now, for me, the big concern I had was, it's well known that if you're not emptying the bladder properly, and particularly if you're having to strain to get a flow going, the big risk is that you push urine back up, and eventually you're at risk of kidney infections and so on, which is not good. And having had your orchitis once, I vowed never to have that again. So when in 2024, the specialist at Royal Surrey looked at the results and said, really, you could go on to, there is another frequently prescribed medication, finasteride, which again could have helped, but I wasn't so keen on starting another medication, because the feeling is really the time for that had passed. The time was to actually take action at source. So when the subject of surgery was raised, I was kind of receptive. I didn't really push back on that at all.
No, I was going to come on to kind of your surgery next as part of my next question. So thank you for leading us on to that. I suppose, could you just tell us a little bit about some of the options that were available to you, and kind of what you did to help you decide what was the best option for yourself?
Sure. So I had done some reading into the techniques, because I'd always, if you think about it, with an enlarged prostate, one of the possible or probable outcomes is that at some stage you need surgery. So I'd read into it. I was not a great. So let's talk about the common procedures. So you can have TURP, the transurethral resection procedure, which is done by a surgeon with a scalpel, to remove tissue from the inside of the gland. But there are some newer robotic techniques which basically all have a similar concept, and they use a robotic probe, which travels up the urethra to the neck of the bladder, and then it basically uses different methods to remove tissue from the inside of the gland. So you can have Resume, which uses steam jets, needle thin steam jets. You can have echo laser, which, as the name suggests, uses laser to do it, or you can have aquablation, which uses cold water. So I had read into these a bit previous to reaching the point of surgery, and was attracted to aquablation because, from my reading, it's highly effective. It seems to offer fast recovery and fewer side effects than some of the others. And so, armed with that, I met Vissam at that stage. He took me through again those procedures, and we weighed things up back and forward. And I expressed really quite a strong preference for aquablation. And Vissam told me that in my individual case, the 3D shape of my prostate gland meant that aquablation would be probably that would be the choice method to use, and so that's what I proceeded with.
And I suppose the $1 million question that everybody wants to know is, how did that surgery go? Did you have any side effects that you had to deal with? Was it a success?
It was highly successful. Side effects, none. The procedure is under general anesthetic, so that's fine. I was hospitalized for one night only, discharged home the following day. I was catheterized immediately after the procedure, simply because everything around the urinary tract swells up a bit because of the intervention. But on day 2, once I demonstrated that I could empty my bladder with the catheter removed, I was sent home. That was fine. I got on with it. At first, you pass a fair bit of blood. I mean, it's not unsurprising. So that I passed a fair bit of blood in my urine for just for a few days. By day 14, that had stopped completely and has never come back. I would say that for a following probably 6 weeks, I felt a little bit of no more than discomfort, but kind of a little bit of sort of increased frequency, a bit of irritation, burning sensation when I was urinating. But again, it's not surprising. That was, my system was reacting to being mildly abused, shall we say. But I would say by 8 weeks in, I was completely back to normal, all resolved, and the results have been fantastic. We did a Uriflow test 1 calendar month after the procedure, and I had tripled my urine flow rate on a very good profile, and all bar 30 milliliters, I was emptying my bladder. And perhaps 2 great things came out of it. One, now at night, typically I'm only up once in the night, and it's a 30-second job to get up, have a pee, and back to bed. None of this standing for what seems like ages, trying actually to get a flow going. So that was great. And the other benefit that came from it was the procedure produces tissue samples. So several samples were cultured, and I'm happy to say there were only benign cells. There were no malignant cells. So, if you like, that was the ultimate proof that what I had was a benign prostate. There was nothing worse than that. So I've spoken with Vissam 2 or 3 times, and I just say I'm fixed.
That's brilliant to hear. Yeah, I'm so glad that you had such a positive outcome from your treatment, and that you're now, living a much, without those complications
Yes,
that you had
indeed.
previously. So finally for me, this is a question we ask everybody that comes onto our webinars, but what advice would you give to other men dealing with an enlarged prostate, or those that are concerned about symptoms developing?
Well, a couple of 2 or 3 things. One, don't be afraid of PSA results. I think they look for less than 3. Well, I've never generated a number down there. I've been well, 7 to 15, and the last one that I had, which was just over a year ago, it was 9.8. So, don't immediately get alarmed. It's a test that is an indicator, but I think one thing to push for, if you're able to, is to get some of these other backup examinations that I've described. The Uriflow test is simple and easy and quick, but is pretty informative. I would say, and I'm happy to see the rapid progress in the use of MRI as a non-invasive test to give more precision as to what's going on. So I would say, if you think you've got these symptoms, then go and check it. Some of these tests are very quick and simple to do. I think one other thing I would say is fitness is a great thing. For me, it's swimming, so I'm in the water 3 or 4 days a week. But I just find that the natural benefits that you get from just your system being that bit fitter, it helps. Actually, it helps with just managing the symptoms. But also, if you do get to the point of having surgery, it helps with the recovery. It definitely does. It's faster. It's great. I mean, in fact, one of the things I was barred from the pool for 3 weeks, which was tough. So that's it. And I think lifestyle stuff, I didn't go in for much of that, and things like diet and so on. I don't hold much store by, you can go on YouTube and see all these videos that eat this one thing for 3 weeks and your prostate will be fixed. I don't really go for them much. I think eat and drink sensibly, keep fit, or get a little bit fitter. In my case, as I said to you before we were chatting, I drink far too much coffee, which is a well-known bladder irritant. And in fact, I was banned from caffeine for 4 whole weeks after the procedure, which for me was quite tough. So, I mean, I think there are things like that, and obviously, don't put yourself in situations where you're going to be without access to a toilet for a long, long time. The very first time in 2008, when I went to Royal Surrey, to the urologist there, the one thing he said is I was leaving. He said, don't sit on a full bladder because it just puts pressure on, makes you uncomfortable.
Great. Thank you very much, Roddy. Some excellent advice there that I'm sure our listeners to this webinar, have taken on board and they've found really useful. So I just wanted to say thank you so much for sharing your story. We really appreciate it.
Yeah, no, it's my pleasure to help and do it.
Okay, so thank you. And one final reminder just before we move on to Wissam's talk is, again, putting your questions in the chat. We can answer some of them, and it'd be great to get some questions in for Roddy towards the end of the webinar. So now I'd like to introduce Mr. Wissam Abu-Chedi. He's a consultant urological surgeon at the Royal Surrey NHS Foundation Trust. And he's renowned for his expertise in minimally invasive procedures for prostate cancer and benign prostatic enlargement. With over 600 robotic surgeries performed in the last 3 years, Wissam is recognized for his expertise in Royce's, I hope I pronounced that right, sparing robotic prostatectomy, a specialized technique designed to optimize continence and sexual potency after surgery. In addition to his work in prostate cancer surgery, he employs state-of-the-art treatments for the management of benign prostatic enlargement, ensuring his patients benefit from the most advanced and minimally invasive options available. He's going to talk to us about some of these options for us this evening. So, Wissam, over to you.
Thank you, Jonathan, and thank you to the whole Prostate Cancer UK team for hosting this interesting event. Let me start by sharing my slides. So, hello, everyone. Following from Roddy's testimony, I'm going to talk initially about understanding an enlarged prostate and how to test for it. Like, what are the tests? What are the treatment options? What can we do? But like, first of all, the most important thing is identifying that you have a prostate enlargement. And there are a number of tests that we as urologists would offer you when you come and see us. The first and most important one, obviously, is the Uroflow test, which Roddy referred to. And that's a test that's very simple to do. We just ask you to empty your bladder in a jug, as you're seeing there on the screen. And when you do so, it generates a curve for us. And depending on the curve, we will know what's your maximal flow, what we call the Qmax. The Qmax should generally be above 25 for it to be normal, but we tolerate it for levels up to 50 milliliters per second. Anything below that is very low and is probably caused by a benign enlargement of the prostate. The other important test that we also offer in order to look into the effects of prostate enlargement is a bladder scan. Again, it's a very simple, non-invasive test where we look at the bladder after you've emptied your bladder in order to see whether there's any residue left, whether there's any urine left that you didn't manage to empty. And that is important, and we'll come back to that in the next few slides. Another test is the cystoscopy. A flexible cystoscopy is done under local anesthetic. It's done by going through the eye of the penis all the way to the bladder. So we go through the urethra, which is the water pipe inside of the penis. We go to the level of the prostate, having a look at the prostate itself, at the bladder neck, and then we look and examine the bladder itself. And this test is very important in giving us more details about the size, the shape of the prostate, and most importantly, the effects that the obstruction has had on the bladder itself. Another test that we use sometimes to assess the size of the prostate is a transrectal ultrasound. And that's when we insert an ultrasound probe up the back passage in order to look at the prostate and measure its size. And another very important test in our arsenal nowadays is the prostate MRI. The prostate MRI gives us an idea about the size, the shape of the prostate, and most importantly, it also provides us with information about any potential suspicious areas in the prostate. Because as you've heard so far, prostate enlargement is completely separate than prostate cancer, but both conditions can coexist. So someone can have both an enlarged prostate and prostate cancer at the same time. And the prostate MRI is really useful because it gives us an idea about the size, but also tells us whether there's any suspicious areas in the prostate that we would investigate further with a biopsy before actually treating the enlarged prostate. Now, once we diagnose, so you went to the hospital, you've seen your urologist, and they've diagnosed you with an enlarged prostate. Some men say, well, it's just part of aging and let's just ignore it. Let's just wait. The symptoms aren't that bad. It will get better. It's just gonna pass. It's normal aging process. Well, let's not do that because these are pictures of bladders that I'm going to show you. So this is a trabeculated bladder. You can see the ridges there. There is the signs of basically the bladder muscle working overtime, pumping as hard as it can against an obstacle. And then eventually what happens is that that muscle becomes tired and starts giving up. And that's when we face an acontractile bladder, so a muscle that is no longer working, leading to these form these what we call diverticulum, that's pouches in the bladder, which are herniations through the muscle. So these pouches will fill with urine and will not empty because there's no muscle around them. It's just your mucosa. So this can lead to urinary tract infection. It can lead to the development of bladder stones, and it can then also lead to hydronephrosis, what we call swelling in the kidneys themselves and deterioration in your kidney function. So ignoring the problem is never the solution. There are many options, many treatment options, including lifestyle management, medications, and surgical options. So I'm going to start talking to you about the lifestyle management, which Lisa is going to address after my presentation. So I'm just going to briefly mention two important things. One is caffeinated beverages. So Roddy mentioned that after I performed this procedure, I asked him not to drink caffeine for 4 weeks. So I didn't ban him from drinking coffee. It's the caffeinated coffee. So there's no problem with drinking coffee and tea. It's just drinking the decaf options. So reducing the amount of caffeine that you drink will have a very important impact on the urgency and frequency of your urination. Another essential thing for men that wake up during the night to empty their bladders more than once is to always empty your bladder before going to bed and to limit your water intake, your fluid intake. So 3 hours before going to bed, you should only have sips of water if you're thirsty, but you should not be drinking 3 hours before going to bed, and you should definitely empty your bladder before going to bed. Lisa will also discuss other lifestyle management options. In terms of medication, I was looking at the questions in the chat, and there were a lot of men mentioning tamsulosin, finasteride. So let's talk about all the drugs that are available. So we can start with the alpha-1 blockers. So that's tamsulosin or alfuzosin or silodozin. So there's a number of medication. So tamsulosin, alfuzosin, the alpha blockers, they work on the muscle cells within the prostate and at the level of the bladder neck. By relaxing the muscle cells inside of the prostate, it allows for a better flow of urine. The side effects of tamsulosin or alfuzosin, the main two side effects, one is that they can cause dizziness or vertigo in 5 to 10% of men. The other most important symptom as well is that in 40 to 50% of cases, they can cause dry ejaculation. So alpha-1 blockers, tamsulosin, alfuzosin, do not cause erectile dysfunction. They only cause dry ejaculation, which only lasts while you're taking the drug. So 24 hours after stopping tamsulosin, you'll have normal ejaculation. Dry ejaculation is when you have an orgasm, but nothing comes out. Instead, the semen goes back into the bladder and goes out with the urine when you empty your bladder. So that's for alpha blockers. 5-alpha reductase inhibitor is finasteride or dutasteride. Finasteride is one of the only treatments we have that actually shrinks the prostate size by up to 35%. So it's effective because it reduces the size of the prostate, but it comes with a price. It causes a lot of side effects, not a lot, but like 10% of patients have erectile dysfunction. 2% can have irreversible erectile dysfunction even after stopping the medication. It can cause gynecomastia, so swelling of the nipple. And so it has a lot of side effects for men that are sexually active. So I would never start someone who's sexually active on finasteride without properly counseling them about the potential side effects. MRAs are muscarinic receptor antagonists, such as tolterodine, solifenacine. So these are medications that act on the bladder by relaxing it. So both muscarinic receptor antagonist and beta agonist, which is tolterodine, solifenacine, or mirabegrin, these drugs focus more on the irritative symptoms, such as increase in urgency, increase in frequency, waking up more at night. So they do not actually work on the prostate, but rather on the bladder, allowing it to relax and not be irritated by the obstacle caused by the prostate. Again, mirabegrin, beta-3 agonist, can have the side effect of increasing blood pressure. So men that have high blood pressure or take many medications for blood pressure, this is not the best drug to start them on. The muscarinic receptor antagonists such as tolterodine, solifenacine can sometimes cause dry mouth, constipation, and blurry vision. And they're not generally well tolerated. PDE5 inhibitors, I saw that one of you raised a question about that in the chat. So PDE5 inhibitors are Viagra. So it's actually tadalafil, which is a low-dose Viagra tablet of 5 milligrams. And that when taken daily on a daily basis can help by improving the urine flow. And finally, there's also plant extracts such as saw palmetto and other treatments which have never been proven to be effective, but some men, when they take them, I believe it's placebo effect, but they feel that they have improvement. But there's no study to actually prove that these plant extracts actually work. So when we're considering what treatment to offer you in terms of tablets, we always consider a number of things. One is what kind of symptoms you're suffering from. If it's more to do with obstructive symptoms, such as weak flow, incomplete emptying of the bladder, hesitancy, intermittency, then we focus more on the alpha blockers, tamsulosin, or the 5-alpha reductase, such as finasteride. So if the prostate is not too enlarged, if it's less than 40 grams, tamsulosin alone is prescribed. If it is more than 40 grams, we can add finasteride to the mix. When it's storage symptoms, such as increased frequency, increased urgency, and nocturia, so waking up at night, then tamsulosin is usually combined with either mirabegron or tolterodine. So either the muscarinic receptor antagonist or the beta-3 agonist, which would relax the bladder and allow for less frequency and urgency. And finally, if someone's having urinary symptoms, obstructive symptoms, combined with erectile dysfunction, then tamsulosin combined with tadalafil 5 milligrams daily is actually a very good option. So that's the best in terms of medication, in terms of tablets that we can offer. But what if the medication is not enough? What if, although you're taking tamsulosin, you notice that your symptoms get worse and worse? One of you mentioned in the chat that he was told that tamsulosin is not effective after a few years. It's not that it's not effective, it's just that the prostate becomes bigger, and then with the prostate increasing in size, tamsulosin just stops working. So one of the options is a TURP, a transurethral resection of the prostate. So I'm going to show you a quick video of how that is done. So a TURP was up to like maybe 5 years the gold standard, which was the procedure that was mostly done for men with prostate enlargement. So we go in through the eye of the penis to the level of the prostate, and then using plasma energy, we go in and resect. We shave off that part of the prostate that is obstructive to create a channel, a big hole, allowing for a better flow of urine. Now, this is considered an invasive procedure because it leads to more side effects than other minimally invasive options. So the patient is hospitalized for 2 nights after this procedure with a catheter, and the catheter drains the urine, and we have irrigation as well in order to avoid clotting. The main side effect is that it can cause dry ejaculation in up to 75% of cases. It can affect erection in less than 2% of cases. Continence is rarely an issue. It's only the case in less than 2% of cases, having a urinary leakage. The risk of bleeding is about 2% as well. And there's always a risk of stricture, so narrowing of the urethra due to the use of the instruments that are in the urethra for a period of time. And it's worth noting that the TURP itself has size limitations. So usually, to be safe, we only offer TURPs for prostates up to 80 grams or 80 milliliters in volume. Anything above that, we can no longer offer a TURP safely. The other option, which is also considered invasive in the term that it can lead to dry ejaculation, is HoLEP. So HoLEP surgery is the same concept as a TURP, but instead of shaving the prostate, instead of resecting parts of the prostate, here what we do with HoLEP enucleation is going to the level of the prostate, and then using laser energy, we enucleate the prostate. It's exactly like if we've had an orange where we remove the inner core and then leave the outer layer, which is the capsule that you can see here. So we enucleate both lobes of the prostate. I think someone in the chat mentioned that they're having a HoLEP procedure tomorrow, so good luck with that. So once the lobes are enucleated and they're in the bladder, we then use a morcellator in order to remove that tissue and morcellate it. So the HoLAP has the advantage of being a procedure that we can use for bigger prostate sizes. So prostates that are bigger than 80 or 100 grams. There's no size limit, so prostates, men can have a HoLAP procedure, which stands for holmium laser enucleation of the prostate, for prostate size up to 300 or 400 grams. Now, moving on from the standard treatments to more of what we call MIST. MIST treatment is minimally invasive surgical treatment options for prostate enlargement. And we're going to start with the aquablation. Aquablation, I'm just going to open the video here. Okay, I don't know why it's not, okay, so it's not. So aquablation is done by inserting an ultrasound probe. It's done under general anesthetic. I forgot to mention that both TURP procedure, the aquablation procedure, and the HoLAP procedure, they're all done under general anesthetic. So it's done by inserting a probe up the back passage while you're asleep to look at the prostate, and then we insert the aquablation probe. And then using a robot, we start by mapping out the prostate, by telling the robot which areas of the prostate we want to target with a water jet and which areas we don't want to target, that we want to spare. The advantage of that is that in this technique, the risk of dry ejaculation is as low as 9 to 10% compared to 75% with a TURP, and even more than that with a HoLAP procedure. So this area here will be spared at the level of the apex, allowing for better functional results. And what happens is, after we map out the prostate, we then activate a high-intensity water jet that penetrates up to 2.5 millimeters inside of the prostate. 2.5 centimeters, sorry. So you can see it here on the screen. That's the live video of the water jet that's shredding the tissue. So the water jet starts shredding the tissue, and that leads to the formation of a channel. It is a heat-free technology, so we're not using energy or heat. We're just using a high-intensity water jet. So that's for the aquablation. Patient usually stays in the hospital for 1 night, and then the catheter is removed the following day, and the patient goes home. Next treatment on the list, which is also a minimally invasive treatment, is the Resium treatment. So Resium treatment entails, it can be done under local anesthetic, but it's a bit uncomfortable, to be honest. So most men still have it under general. We go in through the eye of the penis to the level of the prostate, and then we inject steam, water vapor, inside of the prostate at multiple locations. And that, in time, leads to the shrinkage of the prostate. Now, after a Resium procedure, you go home on the same day. The procedure takes about 15 minutes. You go home on the same day, but you go home with a catheter, and the catheter stays in place for about a week, after which it's removed. The limitations of Resium and echo laser, which I'm going to show you in a bit, is that if you have a midline, what we call a midlobe, which I'm going to show, it's something here. So if the enlargement is not just on the sides, but it's also here, then at the middle of the bladder, at the bladder neck, then Resium or echo laser might not be your best options. Now, echo laser is another minimally invasive treatment, and the advantages of it is that most cases are done under local anesthetic. So it's done by inserting a rectal probe, again, 80% under local anesthetic, 20% under general, and then we would insert the fibers transperineally. So through the skin area between your back passage and your scrotum, we will insert the fibers in the prostate, and then by activating the laser, we would create holes within the prostate, kind of like the Swiss cheese effect, okay? And those holes will then lead to the shrinkage of the size of the prostate, leading for a better urine flow. Again, this might not be the best option if you have an enlargement with a middle lobe as well. So that's one of the limitations of that. So take-home messages. Take-home messages, first one, I think we've made it abundantly clear that prostate enlargement has nothing to do with prostate cancer. There are completely different condition, but they can coexist. And I think someone in the chat was mentioning that he has prostate cancer and enlarged prostate at the same time. So this is common, and that's why the use of MRIs in order to assess the size of the prostate and see whether there's any prostate cancer is very useful nowadays. Enlarged prostate can cause troublesome symptoms and it deserves attention. So ignoring the issue or just wishing it off and just hoping that this thing will disappear is not the solution. And sometimes what happens is that your body becomes accommodated to the symptoms, and then you don't feel that it's something urgent that you need to take care of, but then eventually your bladder is struggling, and down the line you get to a stage where you go into retention, and even then, if we offer you treatment, your bladder would still not function appropriately because the muscle is too weak by then. So don't wait. If you have symptoms, know that there are effective medical treatments that are available. And if the medication is not enough for you, if it's not providing you with enough relief, there are minimally invasive and modern surgical options which are safe and offer excellent results and a very quick recovery. So doing nothing is not the answer. Help is available and your quality of life can be restored. There's no need to wake up 4 or 5 times a night. There's no need to always be on the lookout to where the closest toilet is because you need to go every 30 minutes. There's no need to wait 30, 40 minutes in the toilet for your flow to start. There is a way to solve that, and just seek help, ask someone, ask your GP to refer you to a urology team, and this will be taken care of. Thank you. Back to Jonathan. I'm going to stop sharing.
Thank you so much, Vissam. That was such an excellent talk. So much, detailed descriptions around the various different treatment options. I'm sure our men watching on this webinar will have really appreciated that. I'm now going to pass us over to Lisa, who is hopefully now been able to join us live, and we'll talk through some kind of lifestyle change tips, and then also a little bit of around the support that we can offer as a charity to men with enlarged prostates. Lisa, are you there?
Hi, Jonathan. Yes,
Hello.
thank you. It's been a bit of a mad dash back from London for me, but I'm glad I'm here in time. Thanks very much, Roddy, for your lovely talk. I was listening to it on the train, and Wissam, what a great presentation. So I just wanted to come back in and say a few things about some more lifestyle changes that might help some symptoms. So, for example, making sure you drink enough. So if you don't drink enough, the urine becomes very concentrated, and that can also irritate the bladder. So you need to be aiming to drink between 1.5 and 2 litres a day. However, it's not an exact, so you do need to play around with it a little bit. You basically want your urine to look clear and yellow to sort of straw-like. If you're not drinking enough, as I say, it can cause frequency because of the irritation. Okay, I know Wissam and Roddy have both touched on this, but not drinking caffeine. So decaf is great, so that doesn't irritate the bladder, and also fizzy drinks, sweeteners, and alcohol and citric juice. So for example, plain orange juice or apple juice, they can also irritate the bladder and cause some symptoms such as frequency and urgency. It's also a good idea to drink evenly throughout the day. So spacing your drinks out rather than trying to drink a lot all in one go. And I think Wissam said this, so it's always good to try and stop drinking about 3 hours before bedtime. So that allows the fluid that you've drunk to filter all the way through so you can pee it out before you get into bed. If you experience some swelling in your legs, it's also a really good idea to elevate your legs above heart level for about an hour before bedtime. And that's so that any excess fluid that is in your legs can drain back into the bladder. So then when you have your final pee before bed, it empties that out. So then it's not circulating fluid during the night. It's also a good idea not to go just in case. So only go when you feel the need to go, when you've got a full bladder, because actually bladders are very clever and you can train the bladder. So if you start going more frequently just to be on the safe side, that can actually then, it tricks the bladder into thinking that you only need a small amount in there to make you go. And that leads me nicely on to something called bladder retraining. And that's where, when you feel the urge to go, try and busy yourself to take your mind off it. Once that second urge comes back, then that's the time to visit the toilet. And you should be able to stretch out the time in between. So therefore, that will help with the frequency if you're going more urgently and quickly to the toilet. Pelvic floor exercises can also play a really big part for both benign enlargement and also erectile dysfunction. So there is a big band of muscle that wraps all around the pelvic area. So that encompasses the prostate, the bladder, and the bowel. And having a really firm pelvic floor muscle can support the bladder and the prostate, which can then lead to helping with some symptoms. If you want to chat about pelvic floor exercises, then you can always contact us and I'll give you some details in a moment. We also have a really good booklet on our website. If you just type into the search pelvic floor exercises, then you can get our health information on that, which talks you through a step-by-step guide. We also know that men who have a bit of a tummy, so they're a bit obese or overweight, that can play a massive part on the bladder as well. So keeping fit, like Roddy said, maybe try to lose some weight if you can, and also stop smoking. So smoking is a big factor with regards to bladder symptoms. And then the last thing, as I was saying, everything is all very close proximity. So avoid constipation. If you're constipated, that can put pressure onto the bladder and the prostate, and that can lead to some symptoms. So try to avoid that and straining. And then finally, I'll move on to how you can get in touch with us. If one of my lovely, thank you very much. My colleagues are sharing the slides for me. So if you want to speak with a specialist nurse about an enlarged prostate or anything to do with what we've covered today, then you can give us a call on 0800 074 8383. If you listen to the options, it will say which option is the nurses, and it is option 2. So you can give us a call. Now, what I will say is my colleagues are a little bit overwhelmed this week with calls. So if you are going to call, it would be really good if you could wait till next week if that's possible, just because tomorrow is going to be a very busy day for us and I don't want you to be disappointed that we might not get round to talking to you. Also, you can have a look on our website, prostatecanceruk.org. You can download or order our publications from there, and you can also visit our online community. So there you can chat with like-minded men. You can discuss symptoms, side effects, and what other men are doing. Thanks very much, Jonathan.
Thank you, Lisa. Okay, so that's the end of our the talks that we're going to be doing in this webinar, and we're now going to open it up to the Q&A session. So I think I'm going to be welcomed on screen by the rest of the panel. So yeah, just a reminder that if anybody still has any questions that they'd like us to answer, you can drop them in the Q&A section at the bottom, and Meg and Grace will be able to put those up to me and I'll be able to ask them to the panel. So starting things off, and apologies, I'm going to have to look across to my second screen here to read the list of questions out, but I will start going through them. So first one, I think is possibly to either Lisa or Vissam, it doesn't really matter, but are there any natural methods or kind of natural online products for reducing prostate size that can be taken before medical intervention? I know you've touched on this a little bit in the talks already.
So there are no drugs other than finasteride. There are no drugs or medication or natural products that you can take to shrink the prostate size.
Yeah, so would you mind if I just chip in there a little bit as well?
Yeah, of course.
So lots of men do say, so I know Wissam, you mentioned about saw palmetto, which is one of the herbal products available. And there's limited evidence to say that any herbal products work. Some men do say to us that they do, and I know Wissam was saying that perhaps it's a placebo effect. What I will say, if you do want to try that, is one, speak to your GP or your consultant first, because they can interfere with other medications that you may be taking. And also secondly, if you are going to, please do your research. Just because it says natural or organic or herbal does not mean A, it's it's produced in the UK, and also it doesn't necessarily mean all of the ingredients are safe. So please do your homework if you do want to go down the herbal route.
Yeah.
Sorry, Jonathan, just wanted to throw that in there.
No, that's perfect. I think I'm going to just add in from the health information side of things as well, of don't just trust, Dr. Google. Make sure that the information that you're reading is from trusted sources. Any of the major charities are trusted sources, especially if you can see something called the PIF tick on their information. You can guarantee that that is being created through the strongest evidence possible, and it adheres to various different principles. We have it as a charity on all of our information, so always make sure that your sources are trustworthy. And like Lee said, if you're concerned, if you've got any questions, call the nurses anytime other than tomorrow, because they're a bit busy, but after that it'll be completely fine. Okay. So my next question is, this might be one more for you, Lisa. Can regular lengthy cycling aggravate BPH?
Yeah, so where the prostate is situated, yes, it is sort of tucked up under what we call the perineum. So that's the area between the testicles and the back passage. So therefore, that is the area that you sit on. So if you do have an enlarged prostate, that can then put pressure whilst you're sitting on the saddle. It can put pressure onto your bladder and cause your symptoms to be a little bit more. So therefore, yes, it could potentially aggravate your symptoms, but it's not going to cause you harm with regards to your prostate. It does not mean that it would cause prostate cancer or anything like that. So yes, it could change your symptoms or increase them, but it's not harmful to you other than from a symptoms and quality of life perspective.
Great, thank you, Lisa. This question now I think is probably for you, Vissam. It's getting into maybe some kind of technical surgical areas and details, but is a 90 cc volume prostate too big for TURP?
Well, an experienced surgeon can offer TURPs for sizes up to 100 grams, but ideally, the upper limit is 80 grams for a TURP. Now, an advice I would give all the men listening today is to always ask in the unit where you're being treated, what are the options that are available? Because if the only tool that we have is a hammer, everything looks like nails. So if the only treatment that is being offered is a TURP, then that's the only thing that you will be recommended. So most units now in the UK, I would say, have a number of treatments. So at the Royal Surrey, for example, we offer all the treatments nearly all the treatments that I discussed today, and even a few others. So it's important to ask the consultant seeing you, the registrar seeing you, whoever's seeing you, about the treatments that are available, and then ask them which ones they would recommend. If they say, well, that's the only treatment available here, then it's worth trying to find if that's the best for you or not. But to answer the gentleman's question, 91 is on the upper limit of what we would do for it with a TURP.
Thank you. And that kind of leads nicely onto a question I've got for you, Roddy, because I know that when you were deciding which treatment options were suitable for you, you did a lot of reading, but you also talked to Vissam a lot and were guided by him.
Yeah.
But the additional question I'm interested to know is, how did you get kind of support emotionally, or did you ever look for other men with lived experience? Did you ever talk to them about, what had they gone through?
No, I didn't. In fact, I guess I've got my missus to be a shoulder to cry on. So that was sufficient. And as I said, you saw that my kind of story is quite a long one, and I have to confess, in the early stages of it, it was a little bit what Wissam was saying. It was, oh look, it's simply part of growing older, and it was really only when I'd had the orchitis was a kind of wake up call that you can't you just can't leave them to look after themselves. You've got to take action. But no, I didn't. Other than you chat to your mate in the pub, and well, I haven't got it. Well, that's okay. We did talk one time about a friend of one of my friends who has to live with a catheter. He has to catheterize himself to to manage his urine flow. And I did think after that, that's definitely something that's not for me. So if you like, that was one little bit of someone else's experience that kind of drove me towards there's got to be a better way forward than that.
Okay, and sorry, remind me because I can't remember. Did you have a catheter in at all after your surgery, even temporarily?
Just literally just for the first 24 hours.
Okay,
And the test was, it was taken out, and the test was you must empty your bladder. And if you can empty your bladder, the catheter stays out, you go home. And I was able to do that. So there was no need to recatheterize.
okay, great. Thank you for clarifying that. But a couple of different questions that I'm kind of grouping all together in one, and it's a general thing around the symptoms for for these enlarged prostates can be very similar to those associated with prostate cancer. We've already talked about how having an enlarged prostate doesn't mean it will develop into prostate cancer, but how do you monitor prostate cancer or the risk of prostate cancer living with an enlarged prostate? Should these men be doing anything in particular?
No, I think we can all agree, and everyone should be aware that prostate cancer is an asymptomatic disease. So you will not have any symptoms, any urinary symptoms, any erectile function symptom. Nothing is due to the prostate cancer. The only time prostate cancer can lead to symptoms is when it is too advanced and has already probably spread outside of the prostate. So all urinary symptoms are just due to the benign enlargement of the prostate. So it's not as if my symptoms are worsening, then it must be cancer. No, it's just the benign enlargement of the prostate that is causing more and more symptoms down the line when the bladder is starting to weaken, when the muscle is becoming too weak, when the bladder is very irritated. But a worsening of your urinary symptoms is never a sign that your benign enlargement has transformed or shifted into a prostate cancer. That's just not the case.
Thank you for reaffirming that. I think that's one of the key messages that it's really important for men on this webinar to take away is that there isn't that link between enlarged prostate cancer. So thank you for reaffirming that. Looking at some of the questions we've got in, I think one we've got here, and I think you've touched on it a little bit, Bissam, already, but that is, can I choose where I want to be treated, basically?
Yes, you can choose in the UK. You can set, obviously, the waiting list. I think someone on the chat mentioned that they waited a year and a half for TURP, and that's unfortunately the case. The waiting lists in a lot of our trusts are up to 9 months or 12 months for a TURP. Now, the other treatments that we mentioned today, and because they're done in an outpatient setting, like waiting times for some of them is a few months, so 2 to 3 months. So that's why it is worth exploring your options. If the trust where you are does not offer these treatments, you can always ask to be referred to other trusts which offer these treatments. Again, the waiting time will vary. Some trusts offer these options within 3 to 4 months, but you'll have to do your homework. You'll have to have a look or ask your consultant whether they can refer you to another trust, and then you can contact that other trust and ask about their waiting times.
Great, thank you. And then one question I've got here, it might be good to get both Vissam and Lisa's opinions on this because it's quite a general one, but what happens if my treatment doesn't work? For example, if medication doesn't work or if surgery doesn't work, what are the next kind of steps and options?
So if
oh,
obviously, sorry, so if the
that's okay.
medication doesn't work, obviously you shouldn't just give up. We're going step by step. So you would start with the lifestyle modification. If that's not enough and your symptoms are moderate to severe, we would go on to tablets. If like tamsulosin alone doesn't work, we can then look into combination of tablets if that's useful in their case. If that doesn't work, we can then move to discussing all the treatment options. And if you are a good candidate for minimally invasive treatments, we would start with that. If that doesn't work, we can then go down the route of having a more invasive procedure like a TURP or a whole epinucleation where we would remove the whole gland rather than removing a small part of it. So we will go in a progressive approach, but there is always a solution. The number of men that do not get any benefit from any of the treatments, medically and surgery, are very limited and are generally the men that have waited for too long before seeking treatment. And by that time, the bladder is no longer functional, like Roddy's friend that has to self-catheterize. And at that time, whatever we do, even if we remove the whole entire prostate, the bladder is just not strong enough to actually work. Lisa?
I think you've covered it all to be honest with Sam.
That's no worries. Yeah, that was a very good, very detailed answer. So thank you, Vissam. Yes, I think I'm just looking at the questions, see if there's any more coming in. I think, to be honest, that's all of the questions that have come up. So yeah, I'm happy to bring it to a wraps there. So like I said, that's kind of all the time we've got for this evening. One of the last things I'd like us to do is just bring up a second poll of the evening. Oops, I'm not entirely sure how to move on to the next one. Just looking, if anybody on the background team can work out how I share the second poll, that would be really good. Here we go. So it's a nice, simple one. How would you rate this webinar this evening? So excellent, good, okay, or poor. And again, I'll just leave this for a few minutes to give everybody the chance to answer it. Don't know why it was so difficult for me to share it that time. It's not normally so difficult. Right, okay, and I will end that there. Thank you very much. Really appreciate it. It looks like everybody's found it useful, so I'm glad of that. Brilliant. Okay, so just to wrap things up, I just want to say a huge thank you to our panel, Lisa, Wissam, and to Roddy for sharing his story and for offering so much wisdom and insight into his situation. I know it'd be greatly appreciated by everyone who's been listening tonight. I also wanted to give a shout out to the background team, the nurses and the members of the health information team, because as you've probably seen from my background, I'm at home. We normally do these webinars in the office, but we had a power cut in our office this morning, so an awful lot of last minute changes have had to happen. And yeah, I really appreciate the hard effort everybody's done to get this webinar out today. Last thing to say is please keep an eye on your email inboxes over the next few days. We'll be sharing a survey to ask you how you found this webinar, go into a little bit more detail. Your thoughts are vital, helping us shape our information and support, so please take the time to do this. We also hope to be able to share a recording within the next few days. That will be delivered to your inboxes, but will also be available on the Prostate Cancer UK website. Don't forget, there's a wealth of prostate cancer information on our website, and our specialist nurses are also available to answer your questions, and more details that are available on the website. Like I said, there'll be more webinars coming in the future. The next one is scheduled for January, and I will be focusing on treatment decision-making and that whole process. So I'd just like to say, have a good evening to everybody and take care. Thank you.
Thank you. Bye.
Thanks. Bye.